It's so exciting to have all of you here, to have such a wide variety of people from who care about elders and services to elders and people with disabilities. And thank you for coming. As the president of the board of Somerville Cambridge Elder Services, I'm welcoming you to this forum today, an event that bridges our 50-year history with the future that we hope to co-create with you all. We're very pleased to have so many of you involved in this journey. You represent our partners and future partners, experts in many fields related to aging, caregiving, and health, and community members. So thank you all for being here. The SCES Board of Directors represents the community, brings the voice of the community into the organization. Many of us are or have been clients of SCES. My husband and mother both benefited from SCES care services, and my husband for many years was active on this board before he had Alzheimer's. Many of us are also SCES volunteers in money management programs, in delivering meals to people who are homebound, and in many, many other capacities. So we know that elders contribute a lot to the community, and we recognize that suddenly or gradually, all of us may need supports at some point to live the life we want. Because we value the work of this agency so much, I want you to know that every single board member contributed to this forum. On behalf of the board, I want to thank the many others who've made generous contributions to co-create this forum. You'll see the names of our sponsors not here, but as in rotation, you'll see their names and logos in the program booklet, and there's many pieces of information from them around the space here. We also thank the many staff who have been, I was going to say worked tirelessly, possibly roped into, worked tirelessly over the past 6 months to ensure the success of this event, all while keeping going their regular jobs. Last, we thank you, the participants, because your presence and your engagement in all of the conversations that are ahead of us are essential to the success of this event, because today our focus really is how we can all together work together to create and strengthen the future of aging in our communities. Now it's my pleasure to introduce our CEO, Marta Corvello. Marta has only been with us for a year, but she is largely responsible for this event. I bet 90% of you have already met her. And she's making a huge difference in the agency, building on its strong foundation and taking us to a new level. So Marta, I turn it over to you.
Good afternoon, everyone. Thank you so much for being here today. I want to express my deepest gratitude for joining us as we celebrate a remarkable milestone, 50 years of dedicated service by Somerville Cambridge Elder Services. It is truly an honor for me to stand here as the new CEO and reflect on the enduring legacy of vision, compassion, and community service that has shaped our organization. In 1973, as you will see on the slideshow, SCES opened its doors not just as an agency, but as a testament to the visionary spirit of our local advocates. They envisioned a future where our older neighbors could access a robust support system to age in place with dignity and respect. Today, we pay tribute to those founders whose forward-thinking vision continues to make a profound and life-changing impact on our community daily. We stand united by that very spirit. Today's forum focuses on the future of aging, a future that may be uncertain, but one for which we hold a vision, just as our founders did. This vision is rooted in collaboration, where stakeholders from diverse backgrounds and disciplines come together to achieve more than they could alone. In speaking of unity, I want to take a moment to appreciate the magnificent venue we are in, as it embodies the essence of our event's purpose. Sitting on both the Cambridge and Somerville lines, the American Academy of Arts and Sciences, founded in 1780 during the American Revolution, honors excellence and convenes leaders from various fields to examine new ideas and address issues of importance to the nation and the world. During networking, I encourage you to take the time to read Edwin Land's inspiring speech that is prominently displayed here at the Academy. His words serve as a moving reminder that the progression of civilization is intricately tied to the evolution of our collective intellect, a process perpetually refined by the fusion of science and art. As Mr. Land put it, while each person is narrowed by their specialty, the group as a whole is enriched. You may be wondering now, what does this have to do with the Future of Aging Forum today? So allow me to draw the connection for you. Just as the Academy includes individuals who discover and advance knowledge, as well as those who apply knowledge to society's problems, we hope by bringing together such a diverse group of healthcare leaders, community-based leaders, advocacy leaders, public policy leaders, and academic experts today, we can also enrich our collective knowledge, collaboration, and unity in addressing the complex challenges of aging in place. With unprecedented population growth, we must adopt fresh perspectives and prioritize collaboration to meet the surging demand. Equity remains a paramount concern, as older adults and those caring for older adults are often left out of crucial conversations. The world is slowly aging, and by 2060, around 94.7 million older adults will be in the US. Without the proper structural policy changes resulting in health equity improvements, we risk losing people at an earlier age, further exacerbating the disparities for older adults and those across the age spectrum. Today, we have assembled an exceptional panel of experts to lay the foundation for these critical discussions. Much like you, I am eagerly anticipating their insights and perspectives. The significance of public policy in shaping a brighter future for our aging population cannot be emphasized enough. Today, we're excited to welcome two distinguished experts who are leading the charge in addressing the unique challenges and opportunities of aging right here in Massachusetts. Our first esteemed guest is Dr. Elizabeth Chen, who has been Secretary at the Massachusetts Executive Office of Elder Affairs since 2019. In this capacity, she has been a driving force behind the state's commitment to ensuring the well-being of the 1.7 million older adults and their dedicated caregivers across the Commonwealth. Dr. Chen's visionary leadership has been instrumental in providing these individuals with the essential resources to thrive within their chosen communities. Joining us next, we have the privilege of hearing from Dr. Kiami Mahania, who serves as the Undersecretary for Health within the Massachusetts Executive Office of Health and Human Services. This agency is dedicated to enhancing the health, resilience, and independence of nearly 1 in 3 residents within the Commonwealth. Dr. Mahania's expertise and dedication play a vital role in promoting the overall well-being of our community. We are truly honored to have them both here with us today. I extend my most sincere gratitude for your presence and participation in what we hope is one of the many discussions on advancing the future of aging. Now, please join me in extending a warm, enthusiastic welcome to Dr. Chen and Dr. Mahania.
Thank you. Thank you, Marta, for that wonderful, wonderful, and generous introduction. Good afternoon, everybody. It's such a wonderful opportunity to be here today. And I want to thank Leslie for your leadership, and I want to thank Marta and your staff for making it possible to bring all of us here today to celebrate Somerville Cambridge Elder Services 50th anniversary. And so for the past 50 years, Elder Affairs has been able to successfully offer support to older adults because of the invaluable partnerships with agencies like Somerville Cambridge Elder Services, as well as 23 other regional aging services access points. We call them ASAPs. And I recognize lots of you in this audience, so I think you all know the term the shortcut that we use, ASAPs. The ASAP network was codified into Massachusetts law in 1972. And it was originally titled Home Care Corporations. This network was envisioned by many of you in this audience, and it was also envisioned by your predecessors and my predecessors. The ASAP network serve as the trusted advisors and the access point for programs, for services, for support for older adults. And it's not just older adults. When we think about older adults, we also consider families and we also consider caregivers. It is an entire ecosystem around our older adults. And so, it's hard to describe what an ASAP or the ASAP network does, but I thought I'd give you a few thoughts that can hopefully encapsulate the work that we all work on. ASAPs offer counseling and referrals in general for services. And ASAPs support older adults with our cognitive and physical abilities as they change over time. That's just a natural progression as we age. And we offer support so that older adults and their caregivers can together live and thrive in the communities of their choice. We help families navigate decisions when an older adult wants to change their housing or supportive care. I think about our support for the 1.7 million older adults in Massachusetts. That's 1 in 4. I think about our support as supporting through every change in the stages of life as we go from age 60 through to the end of our lives. And that could be well into the centenarian years. And when you think about that, over the course of 40 some odd years, we don't stay in one place, we change. And so ASAPs are there with options counseling to help individuals and families navigate that change. We protect people from ensuring that they are safe in the communities of residents, especially when there is abuse, neglect, or frequently self-neglect. We advocate for residents in skilled nursing facilities through Ombudsman program and also with assisted living residences. And we help to amplify their voice and mediate when needed so that there's a friendly voice. There's somebody. They're not alone. And of course, we conduct assessments, provide case management, and arrange for all those vital in-home services. And thanks to the Aging Services Network, families are met with kindness and compassion in some of the more difficult moments in their lives. What is so beautiful about our work, and we cannot do this alone, we have not done this alone, we do it collectively through the Aging Services Network. What is so beautiful about our work is that often as people age and when they get older, they feel unseen and they feel ignored. And when I travel across the country to meet with my peers, people are jealous of what we have in Massachusetts. They say, oh my goodness, it's amazing. If only we in this state could have that. And so we are a very generous state, thanks to more than 50 years of generosity and brilliance and forward thinking of so many before us, and some of whom are also in this room. And so for those who may not know, I am a gerontologist, My work focuses on advanced care planning, and I know that you will also talk about other aspects of aging later in discussions. And so Massachusetts, as well as the country, is aging. As I said, in Massachusetts, 1 in 4 is over age 60. In 2034, which is 10 years from now or so, there will be more Americans past retirement age than there are children. There will be, in 10 years or so, there will be more Americans past retirement age than there are children. Now, we have a tendency to think about older people as needing help, and that's not true. Older people are working, they're volunteering, they're caregiving. And yes, over time, we all of us, will need a little help at home. We're going to need a little help with grocery shopping. We're going to need a little help going up and down stairs. We may eventually need help in getting dressed and bathing. We work, all of us work in this world of service that strengthens the social fabric, and it enhances and it highlights the work that we do, highlights the goodness that's in our society, and continues to strengthen our social fabric. So I'm grateful to all of you who do this work, and all of you who have been doing this work, and all of you who are training and helping new people and younger people to come into this work. So when I think about the future of aging, I think about the age and dementia-friendly movement. One of our goals at the Executive Office of Elder Affairs is for all 351 towns in Massachusetts to be engaged in some aspect of age and dementia-friendly initiatives. Right now, we have more than 200 communities and communities that are already engaged. So we only have 151 more, and I know we're going to get there. Much of this work starts at the Municipal Councils on Aging, the ASAPs, senior housing residences, and in advocacy organizations. Through the people in this room, we are doing this work hand in hand. This is why I'm so excited to share that our office has recently taken a big step in the age and dementia-friendly movement. Last week, our office, on behalf of the Healy Driscoll administration, released a podcast, a number of podcasts, about the age and dementia-friendly movement taking place in Massachusetts. And the voice that you will hear in these podcasts is the voice of Robin Lipson, who is sitting right there, Deputy Secretary of EOEA. The podcast is called Reimagine Aging. And each episode takes listeners across the Commonwealth to hear about innovative strides taking place to make Massachusetts more accommodating to people of all ages and abilities. You'll hear voices from statewide and community organizations, leaders, older adults, and people everywhere of all ages. And through 6 compelling episodes, listeners learn about local efforts that make the Commonwealth a great place to grow up and to grow older together, including stories about digital equity, affordable supportive housing, expanded transportation, and much, much more. So I encourage you all to listen to Reimagine Aging. I don't think there's a single one of us who doesn't get stuck in traffic. So while you're there, go to either Spotify, Apple Podcasts, or reimagineaging.net. Listen, get inspired, get connected to the stories, and be inspired and feel just the wondrous stories and the people we are helping through the work of the 351 towns in Massachusetts. And so I am very excited that we've all come together today to talk about the future of aging. And I'm very excited to know that you will continue to make Massachusetts a great place to grow up and to grow old together. We'll do it together. Thank you.
Good afternoon. Ooh, that was weak. Good afternoon. Thank you. You can see the difference in style and the fact that Secretary Chen had like beautiful printed out pages of all of her comments, and this is the extent of my preparation. First, I am honored and grateful to represent the Healey Driscoll administration at your event. But so you know, the only reason I'm here is that Martha and I knew each other in our past lives when I was a clinician at the Greater Lawrence Family Health Center, and she was torturing me as the VP of operations. So we go back a long way. What I've learned as I've gotten older is you always take an opportunity to thank people. So number one, I want to echo Secretary Chen's words in terms of thanking you for the work that you do. As you know, Governor Healey is really focused on making the services that the state offers and sponsors more accessible and more simple to use. And as Secretary Chen said, as an ASAP, that is really your key role. And in the name of administration, I wanted to thank all of you. Second, I've only been Undersecretary of Health for about 6 months. And on a personal note, I wanted to thank the two people who were actually very instrumental in convincing me and in shaping my campaign to become Undersecretary. And by coincidence, they're both here today. So I wanted to thank Manny Lopes, good friend and mentor, and Matt Fishman, who's standing in the back there. So thank you. And those of you who heard me speak before know that I try to keep these short because I came from a church where the opening deacon prayer would sometimes take 20 minutes. And so I thought I would make my comments very short. I've had the blessing of being able to live I grew up in one of the poorest countries in the world, in the Congo, but I also got to live in one of the richest countries in the world, in Switzerland. And now I live in a country that has the sort of both worlds were really well represented here in the US. And I've always been fascinated by the role of systems, meaning that the structures that societies build in order to care for themselves. And one of the silver linings of the recent turmoil that we've had over the last 3 or 4 years with both the pandemic and what's been happening on the race side of things is that whether or not people agree on what would be the right response, what is certainly clear is everybody agrees on the importance of the structures that surround us. I think that because of the particular legacy of our society, which is a very individualistic society, it's taken us a long time to recognize that structures actually matter to an incredible degree. And when I was contacted to give a few comments, I was asked to talk about health equity. And one of the places that I really think health equity, the frames that I use, is that I think as Americans, we think of ourselves as individual fish in the ocean, right? And it's really up to us to develop whatever path we want to go. And when you're looking at health equity and the impact of big, gigantic societal forces, you realize that what you're talking about is you're talking about the water. You're no longer talking about the individual fishes. And when I think about health equity, I automatically think of social determinants of health. And I automatically think about what is the lived environment in which we are moving? What are the pollution levels? What are the feelings of safety? What is the availability of nutritious food? What about transportation? How easy is it for people to move around? And you're looking at it through the lens of an ASAP, and you're starting to think about elders, it becomes a really very fine point on all those questions. And there's also the financial frame. What is your income? What are the structures that we've implemented that allow elders to have resources as they age? And for those who don't have resources, what are our structures that we're going to use to help them get those resources? And then when you think about wellness, of course, which is how accessible do we make our sidewalks? One of the things that always strikes me, and I know whether I'm in a wealthy neighborhood or a poor neighborhood, is how long it takes to clear the snow after a big snowstorm. I was always impressed when I worked in Lawrence and Lynn, just how long it took to clean snow off the sidewalks and how fast it was cleaned in the town of Andover where I live. So I think that when we're thinking about health equity, particularly when we're thinking about it in the elder arena, it is very clear that we need to take a holistic approach. Everything interacts, everything affects everything else, which also makes it frustratingly complex and sometimes discouraging. But I think that, let me back up. One thing I've learned through my 6 months now in government is that agencies tend to think in terms of the specific swim lane that they occupy. So we think in terms of programs. If I'm Mass Health, I'm thinking in terms of redeterminations of Mass Health. I'm thinking about how do our people applying. If I'm DPH, I'm thinking about my regulations, what I'm doing around DPH. And one of the most striking things about living in Massachusetts is the amazing plethora of services and programs that are out there. Like, we really are an amazing state. When I worked in the city of Lynn, we had over 110 nonprofits that ran over 300 programs, which meant there was really a program for everybody. But how would you know if you are a disabled elderly veteran that there's actually a program just for disabled elderly veterans, right? In Massachusetts, we don't have the problem of not having enough services, but one of our true problems is figuring out how do we connect all those various services to the people that need them? How do we make sure that that message gets across to the people who need them? And in that way, I think you're celebrating now today 50 years, but in that way, your future is really bright, because that is what ASAPs do. Right? One of the main functions that ASAPs do is to connect people, figuring out what are all the services that are necessary, how are they going to make it livable for those patients. One of the things that's incredibly frustrating for consumers is that you could be filling out an application every 3 months, every year, if you're involved with 3 or 4 of our agencies. And you really need people, that case managers, people that know you on an individual level to help guide you. So although I'm sure that if you work in a nonprofit in Massachusetts, you always feel that you never have enough money or your rates are never high enough, what is clear, though, is that those institutions, like SCES, are really the institutions that will lead us into the future, because those are the institutions that we need to connect our citizens to the services that we're funding. So again, thank you so much for the work that you do. Thank you for your advocacy. And even though I often say no when you're in my office and you're asking for something, I am deeply appreciative and I admire the work that you do. Thank you.
Thank you, Dr. Chen and Dr. Mahania, for giving us such interesting concepts from the state level across the network of ASAPs, connections between ASAPs and other agencies like councils on aging, and the idea of a system that is even broader than that and how we can coordinate those. Now, we're very pleased to be able to introduce our distinguished panel that will go a little deeper into the future of aging, advancing health, equity, and independence. While I'm introducing you, would you come up and take your seats? This is Manuel Lopes, who is interim CEO at Fenway Health and a founding member of the Health Equity Compact. Robin Stone, who is Senior Vice President for Research at Leading Age. Dr. Caitlin Coyle, who is Director of the Center for Social and Demographic Research on Aging at UMass Boston. And our moderator, Olivia Umaran, who is Director of Public Policy and Advocacy at US Aging. And I'm going to turn it over to Olivia.
I want to thank everyone for making the time to attend this event today. And also, I want to thank SCES for putting on this forum. Today is a very special day for me because as I currently live in the DC area now, Boston is home for me. I was born and raised here, and I started my career in Boston as well at MGH. So I'm really excited to be in this room today and to see all of you here and to have an amazing panel as well. So the theme of this event and of this panel is the future of aging. I think that this is a very timely conversation as we have just weathered a storm, which is the COVID-19 pandemic. And I think when you're in a storm, what do? You go inside, you hide, you wait until it passes, and then when you go outside, you see what damage the storm has done. And with the older population, we're seeing now lots of that damage. We're seeing the challenges of the direct care workforce. We're seeing how caregivers need additional support. And unfortunately, we're seeing how older adults still need to be prioritized at all levels. So today's conversation is going to start with a presentation from Caitlin, who will provide an overview of the Massachusetts data. And then we'll get into a discussion with our panel, and we'll have 15 minutes at the end for a Q&A. So without further ado, Caitlin, please.
All right. Thank you, Olivia, and good afternoon, everyone. I want to start by thanking SCES for inviting me to participate this afternoon and to talk a little bit about more who I am and why I was invited to talk today. So I am the director of a small research center at the UMass Boston Gerontology Institute called the Center for Social and Demographic Research on Aging. We do a number of things, but specifically for the last 10 years, we've been working hand in hand with over 75 municipalities here across the state of Massachusetts, helping them to engage their older adults in a data collection process about their needs, their preferences, and thinking about plans for the future, including some of the age and dementia-friendly work that Secretary Chen mentioned earlier. So one of my favorite parts about my job is I get to sort of debunk some assumptions that I go into a community and they sort of think they know what the problems are, they know the needs of their community, and they don't really know why they need data, but somebody told them they did. So they bring me in and I get their older adults together and we do go through a process of data collection. And one of the best parts of that is being able to experience some of those aha moments where people in community sort of have an opportunity to reflect on the reality in their community. So I'm going to talk today, just give a broad demographic overview of older adults in Massachusetts and where appropriate, kind of hone in on the Somerville-Cambridge area, specifically thinking about some of these roots of inequity and causes of inequity around living arrangements, housing, disability, socioeconomic status, and then end on some reflections that I think are important to think about when we think about how these factors impact the local aging service network and the people who live in those communities as we think about the future. Spoiler alert, not much of this data will be super surprising to those of you in the room, but I think as we begin today's conversations, both on the panel and also in the sessions, it's important to root ourselves in data and remind ourselves of the realities that are facing our community and to not just go off of our assumptions. So here we see data from the 2010 and 2020 decennial census, and also as projections to 2030 that are made possible by the UMass Donahue Institute. And this is for the state of Massachusetts. So in 2010, we see that 19% of Massachusetts residents were age 60 and older, and that by the year 2030, that's anticipated to be closer to 28%. Currently, Massachusetts is about 24% older adults, and I actually heard the secretary say recently that that's actually the same as the state of Florida in terms of the proportion of our state that is considered an older American. So currently, we have about 1 in 4 older adults in Massachusetts who are identified as an older American, and we expect that to continue moving forward. Here locally in Somerville, Cambridge, that share of the population is smaller. So we have 13% in Somerville and 15% in Cambridge. And while the share might be smaller, and we can all imagine why that may be, particularly the number of young people who live in these communities, there are more than 24,000 older adults in the area. And what you see here are a similar comparison between the 2010 and 2020 decennial census, and you see for Somerville and Cambridge. You see relatively stable rates in Somerville. The thing I wanted to note particularly here is that in Cambridge, your population of people 80 and over nearly doubled between 2010 and 2020. I think that's particularly important as we think about the work that SCES does, and particularly folks who are in the 80 and older as they face some of the changes that come with age. Also compared to the state, Somerville and Cambridge are more ethnically diverse when it comes to their older adult population. And so this is for folks 65 and older. So at the state level, we see 85% of the population identifies as white, and that's compared to 73% in Somerville and 71% in Cambridge, suggesting that in Somerville, 27% of the older adult population are people of color, and in Cambridge, that's 29%. So when we look specifically at older adults, not only is the population growing in size, but it's changing in terms of its demographic makeup. Beyond racial identity, older adults in Somerville and Cambridge are more likely to speak languages other than English compared to the state of Massachusetts. So in Massachusetts, 83% of older adults speak English only. And in Cambridge, that's 75%, and in Somerville, 67%. So again, 33% of older residents in Somerville and 25% of older residents in Cambridge speak languages other than English, further illustrating when we think about the future of aging that there's a lot of heterogeneity. Here we see that it is more common for older people of color in Massachusetts, so this is at the state level, to live in multi-generational households. So compared to the whole state of Massachusetts, you see that 29% of adults 65 and older live in multi-generational households, but among Black and African American, that jumps to 56%, so over half are living with others beyond just a spouse. Similarly, for American Indian and Alaskan Native, 36%, Asian Pacific Islander, 49%, other race, which often could include the Hispanic ethnicity, 54%, and 2 or more races, 38%. And I highlight this because I think it indicates and sort of reminds us, particularly for folks of color, that they're closely embedded in families and networks, in this case, living together, and there are economic reasons for that and economic benefits to that, but it also suggests, I'll say caregiving relationships, but sort of caretaking relationships. And as we think about the future of aging and think about the change in the demographics, remembering that although we see a lot of disparity, there's also a lot of richness in these communities and thinking about how they organize themselves. So I just wanted to highlight that that has economic implications, but also from a sort of caregiving social support perspective also has implications. In Massachusetts, most usually, older adults are most likely to own homes. And here in Somerville and Cambridge, that's true, although there are much higher rates of renters here in the Somerville-Cambridge area. So of people 65 and older, 45% of them in Somerville rent their place of residence, and in Cambridge, that's 37%. This has implications for accumulation of wealth. It has implications for the needs of people as they think about being able to stay safely in their homes for aging in place purposes. I also wanted to talk about, for Somerville, Cambridge, that the disability rates are highest among older people of color. So American Indian, Alaskan Native, the 44% of older adults have at least one disability, followed by folks who identify as other race or two or more races. And this is important to think about as we think about, again, the kinds of services that people need, but also about some of the access issues that we've been starting to hear about. You know, one of the things I think about in terms of aging equity, many folks are coming into older age with life courses full of inequity and racism and disadvantage. When they reach old age, they experience a new layer of that when it comes to being able to physically access their community, understanding where to go for help when they need it, the change in their family dynamic and their friend network. So it's almost this compounding effect. And I think it's important to remember that compounding effect is often what I think about when I think about aging equity particularly. And also, when we think about older adults, we often use the cutoff of 60 or 65 plus. We know with human longevity that that can include 3 or 4 or more generations of people with different life experiences, different backgrounds, different health histories. And so this statistic about disability, I think, is important to remember that there's a lot of heterogeneity, a lot of diversity within the older adult population, not just with respect to language and ethnicity, but also in terms of physical ability, cognitive ability, and the whole spectrum. When we look more specifically at disability, particularly here in Massachusetts for folks 65 plus, this is looking at it by race. We see that disability related to independent living challenges and ambulatory challenges are the most common, and that people of color experience these types of disability at higher rates. Again, thinking about the work of SCES and the Aging Service Network in terms of thinking about the kinds of support that people are needing in their home, it tends to fall in this bucket. I'm going to talk a little bit about the cost. Cost of living is a major challenge for those aging in Massachusetts. I think many of us know that. This is the median household income for people 65 and older in Massachusetts is about $56,000 a year. And that's compared to Cambridge, which is $76,000 a year, and Somerville, which is $40,000 a year. And I think it's interesting to talk about that because what we see in the Somerville-Cambridge area is sort of two ends of the spectrum in terms of its socioeconomic status. Of course, there's diversity within, but just in terms of thinking about the type of people that live in our communities, what they need, what they can afford, what they are eligible for, and how that connects with their ability to access services. So this is median household income for older adults in Massachusetts by race. And there are two things I wanted to highlight about this particular slide. One being that non-white older adults are more likely to be living on less than $25,000 a year, which is the set of bars further to the left of the slide. So we see that there are disparities, income disparities across race, particularly including at older age. But the other thing I think is interesting to note here is that there are sort of these concentrations at both ends of the spectrum. So we see a number of folks who are living with on incomes less than $25,000 a year. But we also see another sort of spike, if you will. It's not a true spike, but another little lump over at the $100,000 a year or more. And I think this sort of suggests to me this idea of the sort of shrinking of the middle class and the sort of extreme incomes at both ends of the spectrum. And also, income disparities and wealth gaps are significant across race, and it's also true in terms of gender. So you'll remember that the median household income in Massachusetts is about $56,000 a year. When we look at older males and older females who are living alone, for older males, their median household income is $33,000 a year, and for females, it's $27,000 a year. So when we think about income disparity, we see it across race, but we also see some pretty significant disparities across gender, particularly at the intersection of age. One response to that, is that people are working longer. And so this is Somerville, Cambridge compared to Massachusetts in terms of the percent of folks 65 and older who are still in the workforce. So at the state level, we see that there are over 40% of folks 65 plus are still working. That's compared to 38% in Somerville and almost 60% in Cambridge. So there are certainly economic reasons for people to continue to work, but there are also sort of social reasons in terms of staying connected to one's purpose, staying embedded in social networks, choosing to continue to work as part of a pursuit of a healthy, longer life. But in any case, we're seeing shares of people staying in the workforce longer, which has implications, again, for how they spend their time and their resources. So I just wanted to make a couple of really clear points before we move on, is that older women are less financially secure than men, and particularly women of color has especially high prevalence of financial insecurity. And so in Massachusetts, I'm going to talk next about the Elder Index, which is a measure that our center at the leadership of Dr. Jan Muchler produces for every county in the United States. And so it's a measure that measures the income that older people need to meet their daily living expenses while being able to stay independent. It includes things like housing, transportation, healthcare, and food. And when I say meet the need, I'm talking about a very bare bones budget. It also includes transportation, not the fun kind of transportation or travel, but the transportation needed to get to one's medical appointments, things of that nature. And so you may have seen this in headlines recently, but Massachusetts is the most expensive state in the country for older people living alone. And when we look at the counties here in Massachusetts, I circled Middlesex County since that's where we are talking about today. And for single renters, so when we think about older adults who are living alone, renting their apartments or their units, their homes, we see that the annual amount needed to live in Middlesex County is over $42,000 a year. And that is the fourth most expensive county in the state, only preceded by Dukes County, which is Martha's Vineyard, Nantucket, and Norfolk County. So the issue of economic security is huge in Massachusetts, and even more so here locally in this particular area, and I think it's important to think about that. We know that the average Social Security benefit in this county does not cover $42,000 a year, and so we have to think about how people are making up that difference and how that's affecting their choices. This is an example of that Elder Index budget for a single renter living in Middlesex County who's in what they would refer to as good health. So sort of excluding people who have serious medical conditions. What you see here is that on a monthly level, somebody would need about $3,500 a month to have a very bare bones lifestyle here in Middlesex County. The other piece I wanted to point to is that green section of the bar graph is housing, the cost of housing. And what we can see is that when it comes to this monthly budget, that's a huge portion of what's driving these costs. So we think about all of the solutions that SCES is doing and all of the Aging Network in terms of providing transportation and food and supplements to programs and trying to reduce costs for people, but that big driver of cost is housing, and that's followed by healthcare, which is in the red section of the bar graph. So thinking about the future of aging and being able to think about solutions, I think housing and healthcare are certainly huge factors when it comes to people being able to live on that sort of bare bones budget that I described. So I know there's a lot in there to think about, and I'm hopeful that our panel can think about this context as we engage in a discussion. I just wanted to end with a couple of observations that maybe are a little less obvious. Obviously, the obvious one is that older adults in Massachusetts are increasingly diverse with respect to ethnicity and culture, but also socioeconomic status and disability. And that these things matter when it comes to access and preference for home and community-based supports. And when I think about, again, my sort of thought on aging equity is that we're dealing with life course accumulation of disadvantage layered with the additional challenges that come with age with respect to how do I know what's going on in my community, how do I get information, how do I physically get to the bus stop, how do I get my groceries up the stairs, these sort of practical changes that come with age and how that exacerbates the inequities that already exist. And the other thing I wanted to just highlight is that, I do this work all over the state in small towns and bigger cities. And when I think about Somerville, Cambridge, it's really this idea of aging in urban environments that comes to mind when I think about the future of aging and that there are strengths associated with urban aging in terms of access to public transportation, access to great services and healthcare, lots of opportunities for social engagement and volunteering, if you can access those things. But there are also these additional challenges, the costs in particularly housing, the physical barriers, high competition for resources, so thinking about wait lists and access to home health services, potential isolation from family for folks who maybe their children can't afford to live in urban areas, and so they sort of become a little bit isolated from their family, and then the issues of crime and safety that affect people who live in more urban environments. So with that, I look forward to a discussion with the panel. Robin's laughing at me, like, what are we supposed to do with that? But I look forward to the discussion and the questions, and I hope that provided some context for you all as you go forth today. Thank you.
That was great.
Well, thank you very much, Caitlin, for that very important data. It is amazing to see. It's amazing to see, for lack of better words, how much of a struggle it is to live in Massachusetts. My brother is a real estate agent, and sometimes I just have to close my eyes at some of the prices that he shows me. And I don't know how the average person, and especially an older adult, is supposed to survive in these types of conditions. So we're going to go ahead and start with this panel, and I want to start with Robin. I'm a federal policy person, so I have to start with the federal. I have to. But you have a very unique perspective in that your background, you've had federal policy experience, and then you also have the state experience. In your opinion, in what way has policy shaped the current state of aging and the future state of aging, and also how has it shaped it in the Massachusetts context?
Sure. Well, I want to start by just saying a couple of things. I have to tell you, you are so lucky to have UMass Boston. I actually am. I co-lead the Leading Age LTSS Center at UMass Boston. It is an MOU relationship between our group, headquartered in Washington, D.C., Leading Age National. We also have a Leading Age Massachusetts organization here. Mark Cohen and a number of fabulous researchers at the Gerontology Institute, as well as working with Jan Muchler and Caitlin and everybody else there. There is no other meeting that I go to that takes you to the level of these neighborhoods, these small communities. That's what you need to keep your eye on. And it has a lot to do with federal policy because quite honestly, and I've been in Washington most of my career, so it's about 47 years of in and out of DC. Federal policy can only do so much because the heterogeneity of the United States is unbelievable. And you see it just in looking at Cambridge and Somerville, which are contiguous. You have a very poor population just because renter is a proxy for poverty in older adults. 50% are renters. The highest rate of home ownership among populations are older adults. So think about what you have here in Somerville. So I just wanted to highlight the importance of having access to these data because they are critical and you need to use them as you're making your decisions. And we can't do that at the federal level. We can't make a policy. A Medicare policy is not going to address, even though it's a social insurance program that is the best thing we have ever had. We were talking about this before we got on here. Why do older adults not use federally qualified health centers? Why do people in Somerville who are 65 and over don't need a federal qualified health center, even though they're low income? Because they have Medicare. Everybody, whether you're the poorest person or the most high-level billionaire, have access to a social insurance program. They may need help with paying their co-pays and some other issues around how much they get around certain services. But they all are entitled, which is not true for the under 65s. I think that's really important for us to understand. Probably at the federal level, the best thing we ever did was Lyndon Johnson signing in 1965 the Medicare program, because it leveled the playing field for all older adults. Unfortunately, we haven't been able to do it for the rest of the population, which is, you know, I'm 73 years old now. I'm actually old. I'm an older adult. Started when I was 26, and would never have thought that this many years later, we still do not have social insurance. So that, the federal policy there is significant. The variation in Medicaid and the programs and even the Older Americans Act in terms of the dollars that go to the states is tremendous. So even with the federal policy of state federal match for our Medicaid program, which is health care for low-income people and the biggest long-term services and supports insurer for Medicaid for nursing homes, because it is an entitlement program to nursing homes, and then access to home and community-based services through waivers, which is another issue that we do not have an entitlement to HCBS in the United States. We have waivers that allow states to use dollars to actually, in lieu of nursing home placement, people access the home and community-based services, so it varies tremendously by state. Massachusetts tends to be on the better side of waiver generosity. And you also have, which I want to make clear, you have state programs that top above Medicaid, because as I was looking at the numbers, I'm thinking to myself that, yes, we have a federal Medicaid, state Medicaid match program, and you have a lot of resources here. But you also have people who may be low income, but they may not, for virtue of a number of things, not qualify for Medicaid. So they are living just above the poverty level, and they don't have access to anything. Massachusetts is one of the states that actually has state-only dollars that actually subsidize moderate income older adults. And this is probably extremely important for Somerville, probably to a lesser extent Cambridge. But so understanding the dynamic of federal policy, which with the exception of Medicare, does not have any universality. Medicaid, which is a match program with the state, and as long as I've been watching states for my many years, Massachusetts has always been in the forefront. The other thing is that you have always had exceptional new models of care. When I was in the Department of Health and Human Services in the early 90s, we brought Cambridge Health Alliance, we brought the Commonwealth Care Alliance to DC to talk about the only model at that time in the United States that truly tried to bring together services for older adults and younger people with disabilities. And I don't know, Lois Simon probably isn't here, but we go back a long way. And I currently am on the consumer board for that organization. So every quarter I sit with this organization, so I know a lot about what's going on with that particular SCO in this state. And I will tell you that it's those model development in Massachusetts that has made the difference in what you all do and the rest of many of the other states in this country. The question is, how can the federal government take the models that are successful in certain places and bring them to scale throughout the United States and even sometimes throughout Massachusetts? I will just close this part of my panel just by talking a little bit about housing, because that's a lot of the work that LTSS Center has been doing, affordable senior housing, linked with services through service coordination and then pathways through working with Medicare Advantage plans, special needs plans, SCOs, all of the different types of health insurance options that you have here. You've got great opportunity to actually do more linkage with large housing, congregate housing, as well as some of the other voucher programs that actually we could link much better. And I think you do a really wonderful job of doing that through the ASAP. The ASAP can only go so far because the caseloads are often very large. So how do you use these other partners in the community to get better access to low-income people who are living right now in affordable senior housing? And then as I looked at all of the numbers of renters, the big issue for you in the future of aging here in this area is going to be housing. There is no doubt about it. You're going to have to figure out, just like California is trying to figure it out right now, how do we deal with an expensive area where you've got serious challenges for people who maybe live, if they live to 65, they have a 3 in 5 chance of living till at least 90. We are talking about huge longevity, living on fixed incomes at best. My guess is all those people in Somerville aren't working as much as the people in Cambridge because they're not as healthy. I think these people in Cambridge are people who are still working in universities because there's no tenure. I mean, you could work till you're 100 in a university, and many people do. So I think the challenge is that particularly in Somerville, for the future, is figuring out what are new options for independent living, and then how do you link these services together to keep people in the community, because most people don't want to go, and they could never afford to go into assisted living because there's hardly any assisted living that's subsidized. And then the state really doesn't want to have to pay more Medicaid dollars for nursing homes. So trying to figure that out and then bringing all the services together, that's never going to get solved by federal policy. What I think federal policy can do better is to help with taking away the disincentives to integrate better Medicare and Medicaid, and to bring more resources together so that the states and the locales can actually have more flexibility. And then on the housing side, I love HUD. I mean, HUD is great, but HUD is not the solution to our housing problem. We have to figure out new answers to housing, which include the low-income housing tax credit, which is really right now the only program that is paying for subsidized housing to develop new housing in the country, and to think about what new mechanisms at the federal level could we have for actually stimulating investment in affordable housing. And then at the state, and particularly local level, we have to deal with things like zoning. Get rid of these ordinances that don't let us build small houses, or look at how do we redeploy the housing stock that we've got. And I'll finally say, as I was walking around here today, I was thinking to myself, how do these people carry their groceries up these steps of these houses? It's like being in Pittsburgh. It's another community. This is very much like communities in Pittsburgh, where you can't age successfully in houses with all of these steps. So it just, there's got to be a way to sort of think about that, and I'll stop there because I could go on for about 100 years. And the data are so critical. Take advantage of this. You've got the mother lode is right here at UMass Boston. I was in Austin yesterday at Grantmakers in Aging. They used the Elder Index. They used all those data to talk about health disparities, and you've got it right here in your backyard. So.
Great. Good job.
Thank you, Robin. And I definitely want to get into the housing conversation a little bit more because those numbers, I was just looking at it. It's not leaving my mind. So thanks, Caitlin. Now I'm going to have nightmares about these numbers. But Robin, you did mention something about new models, and echoing your comments and also Dr. Chen's, I believe, was saying that Massachusetts is the best state, and I feel like we can say that objectively. But this is also something where, for example, Centers for Medicare and Medicaid Services, if they're asking for information, they're asking for, can you give us a state example? Can you give us an example of what state is already doing this? I would say 9 times out of 10, Massachusetts is going to be in that comment. So question for you, Manny, in terms of these models and what Massachusetts is doing well. I know we talk about the data, we talk about the challenges, but I want us to also think about what Massachusetts is doing and how we're innovating in the state as well.
Great. Well, thanks for the question. It's great to be here. Congratulations on your 50th anniversary. You know, when I think about all the great things that we've done here in Massachusetts, I think about Logan Airport. I grew up in East Boston, so I'm always thinking about Logan Airport. Terminal C, JetBlue. If you walk down, I believe it's gate, I shouldn't know this, but I do. I think it's gate like 14 or something like that. It has first invented in Massachusetts. And there's a list, that wall, that really impressive wall that you've seen there. There are some things missing there, but there's a lot of things we have to be proud of, right? The first FQHC was born right here in Massachusetts. The first in the country for universal health care, right here in Massachusetts. And there are many, many, many others. But let's just go back first for the FQHC world, because that's the world that I came from. Dr. Jack Geiger brought the FQHC concept, federally qualified health centers, community health centers, operated in the community, operated by community members, governed by a consumer board, right? That really provided direction, guidance, eyes and ears, and what was needed in the community. And I reflect back, and that was probably the second best thing that President Johnson did, which was signed the FQHC as part of the Civil Rights Act. That's right. But there's a story, and I had the privilege of sitting on a panel with Jack Geiger, and he talks about writing a prescription for food when he was practicing in Mississippi at another health center, the second health center in this country. And he was writing prescription for food, and the governor of Mississippi reported him to the federal government and said, he's committing Medicaid fraud because he's writing prescriptions for food. And Jack Geiger's response, Dr. Geiger's response was, the last time I checked the medical textbooks, the cure for malnutrition was food. Here we are, 60 years later, and we're still talking about food. I reflect again, Dr. Jim Taylor, I think I've seen Jan Levison in the room, the founder of East Boston Neighborhood Health Center, where actually my mom got her prenatal care when she was pregnant with me. So I'm a true product of the community health center world. So I'll apologize if I keep talking about community health centers. We went out to San Francisco to see an innovative program called Unlock. And with the help of CMS, Robert Wood Johnson Foundation, we brought the program of all-inclusive care for the elderly to Massachusetts, East Boston Neighborhood Health Center, the first, one of the first in the country, in 1992. And I remember Dr. Taylor saying, okay, to make this program successful here in Massachusetts, listen carefully, 1992, we need housing, food, and transportation. 1992. So really the question that we should be thinking about, it's great to have these bragging rights and being the first, but why are we still having these conversations about food, about housing, about transportation? It's time. It really is time for us to begin to shift the thinking, shift the resources. And I'll be first to say, I think many of you have seen this before, but 80% of what really impacts health happens outside of the exam room. So we've made some significant investment. I would argue there's still more to make, particularly in primary care, being 4 cents of every dollar spent in healthcare. But we need to think about making more investments, like in the ASAPs and other community-based organizations, to come together, coordinate, scale, and really become part of the health ecosystem in a coordinated way, if we're really talking about improving health. Because giving coverage is one thing, and we've done that. Again, we should brag, we should cheer. We were the founders of the ACA, Obamacare. I know I say that It's not a political statement. I say that with pride. But now, really, how do we improve the health and well-being of our population, our older population? This is probably one of the only countries in the world that when you're servicing and caring for an elder, it's not viewed as a job, if you would, of pride, which is amazing to me. Just amazing to me that the individuals, the caregivers, the individuals, the folks working at Somerville Cambridge Elder Services are the ones that we should be giving not only the pat on the back and the shoulders, but making sure that those individuals are not on the lower end of the pay scale as well. So I'll come back just a couple of stats, again, back to the FQHCs, because I think there's an important role here for FQHCs to play in our state. 1 in 6 individuals in Massachusetts receive their care at a federally qualified health center. Over the past 4 years, health centers have seen a 26% increase of individuals in their patient population, individuals who are 65 years and older. So they're coming to the health centers to receive care. I think there's a responsibility now for community health centers to connect with ASAPs and other organizations, because quite frankly, health centers were created for moms and children, and usually in public housing. And folks have aged in place, have aged with the health centers. And I think there's an opportunity now for health centers. Some already have. They've adopted SCO programs, senior care options. Some have moved and brought in PACE programs. But I think there's an opportunity here, again, knowing that 80% of health occurs outside, for health centers to reach out into the community and connect and bring those services together so we could really do what's really needed and maybe tackle some of these other social determinants of health and make sure this population, again, can live healthy, independently at home. So I'll stop there.
Thank you. And this is going into the integration of the healthcare system and the social care system, which they are really siloed systems right now. And I have to say that before I came to US Aging, yes, I did start my career in aging, but then started in public health and then went back. And I was so shocked as to how many conversations were happening in public health around social determinants of health and creating new models when this is already happening on the social care side. And I have to talk about area agencies on aging and what they're doing on the ground to make sure that older adults are able to age well in their communities, at home. So this is a question for both of you, Robin and Manny. What do you think can happen in terms of integrating those two systems? What do you think are some of the barriers to that? And also, how can we use the best of both systems to create an overall system that is going to be more supportive for our older adult population?
Well, I have a very strong view of part of the problem with social determinants of health in this country. And I have a doctorate in public health, so I come out of public health. We're giving social determinants of health to health systems. I mean, why is all of the focus now, all of a sudden, everything is completely medicalized? The dollars around all the new model demonstrations are going to huge health systems who know nothing about social determinants of health. And, you know, we have an extremely decentralized and really underfunded public health system in this country, which is really the reason I believe why COVID hit older adults as badly as it did. Because public health systems have no idea of how to deal with older adults, none whatsoever. They get no resources. There is a tiny little group at CDC that focuses on older adults. I mean, we are talking about no attention whatsoever to the older adult population, which is the population that was hit hardest by COVID. It is always hit hardest by any climate change related event. You look and see who died in Katrina or who died in the wildfires, or who died in excessive heat. And it is older adults who are most at risk. And we do not have a system. We have a medical care system that Yes, they can do good things, particularly if you need, a hip replacement or a cataract surgery. But the social determinants of health, which have to do with the social care and social environment side of the equation, has always been underinvested. Look at how much money goes to the Older Americans Act, a pittance, since it was founded also in 1965. Look and see how much money we put into all of the other issues that you were talking about here, whether it's housing, whether it's nutrition, whether it's transportation, whether it's investing in a good public health system that understands that older adults are part of population health. There are some movements now, there's some fantastic money coming out of the feds. CDC is funding bold centers of excellence that actually are focusing specifically on older adults and their caregivers. And there's a number of different activities that are going on. A lot of this is related to dementia care. And that is great because they're getting the public health authorities to understand dementia care. But now they have to get them connected to the ASAPs. I mean, all of the CBOs at every local level need to be connected, and then they need to be invested in. Give all those dollars that are going to the big health systems, and I hate to say this because we're in Massachusetts, but all those dollars are going to your big health systems. And they are reinventing social determinants of health. And I hope there's nobody from these health systems, but I don't really care because I'll be retiring soon and it doesn't matter. But those dollars need to be, why are you recreating care managers to community health workers? You're sending the community health workers out there. These folks know what community health is. They've been doing it for 60 years. They are in the community. So pass those dollars on. Do not recreate those systems. Pass them on to these systems, whether it's an FQH, whether it's a federally qualified health center, whether it's a AAA, whether it's affordable senior housing that has thousands of older adults living there. They see these people every day. Trust me, they know a heck of a lot more than your nurse navigator that's calling them on the phone. So that's my biggest bugaboo, is that we have medicalized, and we know the data. We've looked at the global data, how much we spend on social care in this country. And it is way, way under what we spend, other countries spend, and that's why we have the highest infant mortality rates among most of the Western industrialized world. We have pretty crappy disability rates when it comes to older adults. And, so we have accepted that, but we also have, and this is where I say federal policy. I talk to CMS all the time. They think I'm like a maniac, I know, but why do you keep putting all of these CMMI demonstration dollars? And the same thing's going to happen with the new guide model of dementia care. It's going to go to these medical systems. And, you have to be a Part B biller. So, they're going to try to find you guys so you can be part of it and help them with the dementia care in the community. But how many dollars are you going to get out of this? So I just think we need to turn it on its head. And Massachusetts could be the start of it.
Yeah, there you go.
I'm sorry.
Oh, boy.
I mean,
You and I should not be sitting together.
No.
Only because I completely agree. Completely agree. And particularly in this state, I think there truly is an opportunity for us to, for the community, by the community, we really have to live by those values and really try to get away from the larger institutions and systems and really begin to think about, again, this is the foundation of community health centers, but it's the foundation of the ASAPs. It was built by the community for the community. And I think that's where we have to pour our resources. Get back to your question around connectivity, and I'm going to put my CIO hat on, because I was CIO at the time of probably the most significant investment that was ever made in this country of any given sector, by the federal government to the sector, and that was meaningful use. In 2009, the federal government decided it was time for healthcare organizations to come out to the 21st century and adopt an electronic health record. And your tax dollars paid for that investment.
Sure did.
We can argue whether or not it was a good investment. There was a lot of challenges to it, but it did help elevate, at least from a technology standpoint, many healthcare providers in particular who are struggling to find the right electronic health record, to develop interoperability. For us in healthcare for a long time, we've always been jealous in the financial sector, because today you have your ATM card, you could be in Japan, Europe, Africa, you put that ATM card in that ATM machine, it'll spit out money if you have it, it will not if you don't, right? Most part. In healthcare in our own country, we don't have that ability. What happened to you at an institution right down the street, we can't see that. So this was the hope of bringing systems together. Interoperability was a key part of that, and to help improve health and care. What was missing of that? Again, it's only 20% of really what drives health outcomes. What failed in that? $35 billion investment. The failure of that investment was not allowing community-based organizations, agencies who are really doing the work in the community, ASAPs, to say, how could I participate in this program? How can I improve my systems so I know what's happening?
The entire LTSS system was out of meaningful use.
Yeah.
Leading Age has lobbied for years at the federal level to move meaningful use into the entire sector so that we actually had interoperability. I mean, it's bad enough that they don't have interoperability between their own systems, which is not, that's a different question. But you're absolutely right. I mean, they were completely left out, and not without lobbying, because there's been a number of organizations that have lobbied really hard for that, but it just has never happened.
Yeah. And again, that's why we're still having these conversations, why we're still talking about health inequities, particularly in communities of color. That's why we're still talking about older populations not getting the services, or not being able to coordinate the services. As the secretary mentioned, how do we really know, particularly if you are living in an under-resourced community, English is not your first language, and then you have a disability,
You don't know anything.
and you don't have a support system. How are you supposed to access this level of care? We should have a system. Let's envision a system, regardless of what door you walk into, regardless of what phone you pick up, someone really could understand your health history, and they have access to the resources available in your community to say, yes, you now have access to this particular service, and I know this is some of the services that are offered already. You have this particular service, and by the way, as you access those services, all that information will go to your healthcare provider, will go to your case manager, will go. So this way, it does feel like a community approach to delivering this service of care. And it doesn't need to happen at the big institutions.
No,
you and I are not going to be able to walk out of the store.
No,
I'll stop there.
No. I worry if I ever need good specialty care, what will happen to me. But because I do believe that those are really important. But when you talk about the level of, for older adults, your typical older adult, particularly 75 and 80 and over, these are comorbid folks, multiple 10 meds, levels of functional disability, cognitive issues even for healthy older adults. And by the way, that is healthy aging to start having some memory loss. So, I mean, this is the whole holistic approach that is needed, which mostly should be addressed by people in the community with then connections with a really good health system. I mean, I don't disparage that because we're much ahead of other countries in that level. But when you get to the basics of what people need, it is just not there. And, to go back to housing, I mean, there are a couple of examples of MA plans right now that are actually investing in housing, and there have been a number of health systems, Catholic health systems, Bon Secours, for example, that have actually put their money where their mouth is in terms of actually supporting affordable senior housing in communities. But often it's also for investment on the real estate side, and not necessarily because they're thinking totally about this being a social determinant of health, that people need good shelter. So, you know, I think while we may not be able to think about how you bring all of these dollars together, we have to think about at least how the partners work together to bring these things together more. And that's something that I know you have a session on social partnerships in one of your breakouts, but first I noticed that there's no housing people there, which I think is really critical for this, but also that how do we work together until we can get something that's more rational, and maybe at some point it will bubble up. But at the very least, you've got communities that could be doing this together, and Massachusetts is open to that. They use housing so much more widely. I don't know if Emily Cooper's here, she's probably not, but I mean, that woman is a mastermind working with Robin. They've done all kinds of clever things, not illegal, I mean, this is the state that probably could do more than almost any other state. So how do you take advantage of that and start moving it? And then think about the community. You've got so many players that could make this happen.
Yeah.
So.
Well, we've talked about a lot. And I feel like we could probably sit in here until December talking about all of these things because they're all equally as important. We talked about health IT, the importance of data interoperability. We talked about housing and also the need for increased investments in the older population. And I have a question for each of you in terms of a call to action for our audience today. In what ways can people support, whether it's through advocacy or through their programmatic efforts, what can they do to really drive the future of aging to make sure that it's a positive future of aging that we can really be proud of? Caitlin, I'll start with you.
Yeah, I'll start with that. So I mentioned I spent a lot of time in local communities doing my work, and so my call to action would be to get involved in your local Council on Aging or your local ASAP, not only as a volunteer, but as an advocate for more resources. When we talk about the budget inequities, those go right down to the very municipal level in terms of how they spend dollars on their population. So getting involved in your COA, your Council on Aging, your ASAP, not only as a volunteer, but also as an advocate for more resources.
You know, I think knowing who your partners are in the community and thinking about unusual suspects too, and advocating for real partnership investments that can be a win-win as opposed to, I mean, what I see happening a lot is that dollars will come down to the community, to CBOs, and because there's so few dollars, that the CBOs fight over the crumbs, as opposed to, and this happened in Vermont when we were evaluating the housing with services model, and rightly so, the AAAs in Vermont were really pissed off because those dollars were going to the service coordinators in housing and not to the AAAs. And part of that was it wasn't designed, they weren't at the table together to talk about how these dollars should be distributed. So I think we need community folks to know who your partners are and truly come together to figure out, number one, what does this really cost to make this happen? The advocacy there is around where are we going to get the dollars from? How much of this is redistributing dollars that are in there and what new dollars do we need? I've seen really, really, really conservative counties that have actually passed tax levies. Really, really conservative counties passed tax levies to go into better investment in the community because people care about their older adults in the community. So how do we work together, advocate for more investment in the budget, but also use the dollars together so that we actually are flexible around how it happens and not try to grab each other's money? Because I think that's been really been to the demise of a lot of community organizations, is that they fight for crumbs. And we've got to fight for bigger money, and we have to share it so that we make this work for older adults living in the community. The other advocacy I would do around the frontline workforce, I don't want to close this without saying that. That's the other side of the work that we do at Leading Age, a lot of work around frontline care professionals. We need a significant investment in these are care professionals. They are not low-wage workers. They are care professionals who are paid low wages. And these folks who are highly skilled, competent individuals who do 60 to 80% of all the hands-on formal care need good compensation. They need wraparound services until they can get financially stabilized. And they need to be seen as career professionals who have career advancement opportunities. That would be the other piece that I would advocate for at both the local and the state level, and building that from the community perspective. And look at the community to develop your community health workers. You know, we've got community of people here already who need to be supported and invested in. So build them into this as well as your older adults. Never leave the older adults out in terms of making decisions around your models, because they need to be the end users need to be at the table first. Thank you.
You know, I know we're talking about programs and services for older adults, but I have to think about those individuals who are not reaching the golden age. And this is in our communities of color. You've seen the report, the difference between life expectancy if you live in Roxbury, Back Bay, or Beacon Hill, which is only a few miles apart from each other, is significant. And that's the health inequities that we have in our system. So as a member of the Health Equity Compact, just a plug, I think we have an opportunity, like we've done many, many times, Massachusetts first. We have an opportunity to get together and pass legislation, a bill that we put on the table that's at the State House, that will help begin to address health inequities, particularly in our under-resourced communities, our communities of color. And I think, and I ask for all of you to take the time. We've already done a public survey where many people, thankfully, here in this state, believe that this needs to be addressed. Again, we've addressed coverage. We're continuing to address cost and quality. Third chapter of healthcare reform is we need to address the gap here. Because it's important for us, again, making sure we're applying all the resources for those older populations, food, housing, transportation, coordination of care, and making sure we're putting our resources. But then we also have to think about those who are not achieving the life expectancy that they should, and say, what services, resources, programs, and systems that need to change or need to be torn down in order for people to live a longer, healthier life in this state. And I strongly believe in this state we can get there, and I look for some of you for your support in that.
That's great. Yeah, I would just add to that real quickly, 2 seconds worth of the fact that this is a life course issue. So you can't get to health equity at the end of people's lives. The reason you've got 50% renters here is because they've had a life course of challenges, probably discrimination, redlining, a lot of things that have gone on that we end up there. So you have to have this crazy way of thinking about investing in the current cohort of older adults, investing in the life course perspective that gets you to either stunted longevity or living longer, but with a terrible trajectory. And then we have to think about new cohorts of people coming up. What's going to happen to the Gen Zs? These people aren't saving, they don't stay in the jobs, they don't have home ownership the way that this latest cohort of older adults do. So that's another piece of this that the state needs to be thinking about, which I know is hard because the budgets are very, very short term, but it is something that we need to be thinking about for the long term. So
Thank you. Please join me in giving a round of applause to our awesome panelists.